Welcome back. Let's talk about the lymphatic system. So the lymphatic system is kind of it's like the ignored vascular piece, and it's so important. And as PTs, we deal with lymphatics a lot. So we're going to go kind of slow through the system and really start with a good review of what the lymphatics do. So as it says in your notes, kind of as a definition, it's a very unique one-way system that returns lymph fluid through vessels to the cardiovascular system. So the arteries and the veins are all part of a big loop. It's a two-way system. We send blood out and then we pick it up and send it back. The lymphatics is really a parallel system to the veins. But there isn't an arterial side to this. It's just on the return trip side. It's a one-way trip. It's sometimes referred to as like the sanitation system. It picks up all the junk that kind of couldn't make it back in the vein and helps return it to the system, to the general circulatory system. So the lymphatic system includes our lymph vessels. It also includes our lymph nodes, our thymus, our spleen, and even tonsils are included as part of the lymphatic system. So the lymphatic system has an important role in helping to fight infection. And we talked about this a little, that part of it we sort of talked about already, the lymphocytes and how they can be called to action in order to create antibodies and fight a known agent. So that's kind of a big piece of the lymphatic system that really takes place in our lymph nodes and some of our main lymphatic glands. But we're going to really focus on the vascular part of the lymphatic system. We're going to talk about the lymphatic vessels that help to remove cellular debris and metabolic waste. This is just a kind of a slide that shows that job and kind of helps to really illustrate the interconnectedness of our lymphatic vessels, the specific kind of organs and glands that help to assist in that job. So in your notes, I have kind of a little cartoon picture of a blood vessel like this, because we're going to revisit Starling's forces, but add in the role of lymphatics. So I'm going to draw my kind of version here that sort of matches what's in your notes. And the arterioles leading into the capillary would not be smaller than the capillary, but I'm going to draw it that way so I have space in my picture. Right, and so then these are the veins that are taking the blood away. So I'm going to add in here green circles to represent plasma proteins. Actually, I'm going to put this in a different spot. I'm going to put it down here so it doesn't get in the way later. The green circles will represent proteins. So let's add some proteins to our blood that will be helpful for our story. All right, let's put in Starling's forces. So we obviously have our hydrostatic pressure, which is an outward force. And we have our oncotic pressure. Let's make that actually let's make it green since the proteins are green. That's pretty good. All right, our capillary oncotic pressure is probably an inward force. Of course, there could be some oncotic pressure in the interstitial fluid, pulling towards it. And hydrostatic pressure in the interstitial fluid is kind of a general outward force, although this is typically 0 millimeters of mercury, so it's probably really small influence. So when the blood arrives on the arterial end of the capillary, so let's just label, this is our capillary here. So on the arterial end would be on this side of the capillary. The hydrostatic pressure, I'm going to put numbers to this story. Again, not to memorize the numbers, but they illustrate the concept. On average, this is around 35 millimeters of mercury. And the oncotic pressure is around 28. Our interstitial fluid oncotic pressure is maybe like 3. We'll just draw like one little protein that made its way out there as kind of an influencer. So at this point, you might either be able to tell just by looking at it, or you could calculate the net filtration pressure. Filtration, again, is how fluid moves out of the vessel. And you take the capillary hydrostatic pressure, and you subtract off the interstitial hydrostatic pressure, which is 0. And then you subtract off the influence of the proteins. So capillary oncotic pressure is 28, but that force is offset by the oncotic pressure in the interstitial fluid. So you take off the 3. That's this guy up here. So if you do the math on that, there is a 10 millimeter mercury pressure gradient driving fluid out. So on the arterial end of the capillary, fluid moves out. And we talked about how this is a good thing because the capillaries are where we deliver oxygen and nutrients, and they can kind of ride the wave of that fluid. So this helps us in delivering necessary items to the tissue that this capillary is feeding. But it's important to remember that, this blood is still flowing by. When you get to the venous end of the capillary, the blood looks a little different, doesn't it? Because fluid left. When you get to the venous end, the hydrostatic pressure has to be less. It's still an outward force, but where it was 35 on the arterial end, fluid has left. That has dissipated some of that hydrostatic pressure. So on average, the capillary hydrostatic pressure on the venous end is closer to 15. We really haven't changed the, I don't know, where should I put this guy here? Maybe the pressure in the interstitial fluid, that's likely still 0, even though fluid has moved out. Remember, the interstitial fluid has almost no barrier to it, so it's very hard to raise pressure in the interstitial fluid when there's the fluid can just spread out. The volume is so big that it's very hard to make any impact on pressure. So what's happened to our oncotic pressure, the pressure of the proteins? See if you know the answer to this. What do you think what's happened to the oncotic pressure on the venous end? And remember, the oncotic pressure is the pressure of the proteins pulling water towards them. Think through if you were in class and I pointed at you and I said, what happens to the oncotic pressure? What would you say? Have the number of proteins inside of this vessel changed? Have they left or gone in? They have not. So there's no reason to think the oncotic pressure should be any different, and it's not. The inward force is still 28. So oncotic pressure is the influence of each individual protein, right? This guy's sucking, this guy's sucking. So it's completely dependent on the number of proteins, and that has not changed. Oncotic pressure in the interstitial fluid still hasn't changed. Maybe that one protein still there. We'll draw it for the story. So what is the net filtration pressure here? Let's see. So we start with hydrostatic. So now we have 15. Subtract off the influence of the interstitial fluid, which is 0. And then subtract off the role of the proteins. So that's going to be 28 minus the 3. That's this guy out here, because it's going to offset the capillary oncotic pressure. And this gives us a negative 10 millimeters of mercury pressure. So we'd actually call that the reabsorption pressure. Negative means that on this end, what's going to happen? fluid is going to move in, which is good because if fluid only moved out, and I think some of you kind of got to this in Unit 1, you're kind of like, well, wait a second, why won't we always have edema all the time if this fluid is leaving out? So I kind of left off the arterial versus venous situation when we first introduced this concept, but you can see here that because the components of the blood change from the arterial side to the venous side, the influence on the net filtration pressure changes as well. So on the arterial side, fluid moves out, and on the venous side, fluid moves in. That all sounds really good, except that the amount of fluid that is able to move back into the capillary accounts for about 90% of the fluid that was originally leaked out. So 90% of the fluid is reabsorbed and then sent back to, the venous circulation, ultimately the vena cava, to return to the heart. But that leaves us with 10% of the fluid that has to be dealt with. So in normal physiology, the Starling's force allow us to have fluid leak out on the arterial side to help deliver oxygen and nutrients to the tissue. And then the pressure gradients have shifted in a way that on the venous end, we reabsorb fluid back in. But this is not a perfect system. We don't get all of the fluid back in. And the reason for that has to do with the fact that there are proteins out in the interstitial fluid that really help yank that fluid towards them, and they don't let it all go, and we can't get it all to go back into the vein. We have to have a parallel vessel to help deal with the 10% of the remaining fluid. So I'm going to draw this as green because for whatever reason, every textbook I lost my pen. Forever makes lymphatics green. So here is a lymphatic vessel. The lymphatic vessel is a parallel system to the veins. It's right in the mix. We actually have like lymphatic little capillaries that can be right next to the capillaries that we've already drawn in. The big difference between the capillary in our circulation and the lymphatic vessel are the type of endothelial cells that create the barrier. So as you guys know, the endothelial cells of the capillary have such tight junctions that proteins cannot leave the vessel. But because of that, that also means that this protein out here that's in the interstitial fluid, I'm going to draw something. Don't draw this along because I'm going to erase it in a second. This protein that's in the interstitial fluid cannot make its way into the blood. It's stuck out there. It's stuck in the interstitial space. And we don't really want proteins in our interstitial space. That's likely a protein that's there from some kind of cell turnover. When cells die and they spill out their contents and your body picks it up. Well, those larger proteins, and maybe I'll even put some X's on here to represent cellular debris, that can't get into the capillary. And we don't want it to stay in the interstitial space. Our body would not tolerate it if a bunch of proteins and cellular debris started to accumulate in our interstitial space. In fact, that would likely cause an acute inflammatory response because they're not really supposed to be there. We have to be able to move them out. And this is where the lymphatic vessel comes in. The lymphatic vessel has larger spaces between their endothelial cells that allow for cellular debris and proteins to get into the lymphatic vessel. The proteins pulling fluid along with them, right? Because they have an oncotic pressure that's pulling fluid along for the ride, accounts for the 10% of remaining fluid. Ends up in the lymphatic which will ultimately get dumped into the larger veins to get dumped into the right side of the heart. So lymphatic vessels are necessary to prevent edema because our normal healthy physiology, we have to have fluid leak out of the capillary. When that fluid leaks out, if we can't get all of it to leave, we will have edema. And the way our body is designed, the venous end of the capillary can reabsorb fluid, but only 90%. Because the larger things that are in the interstitium, like proteins and cellular debris, can't cross that membrane. They pull fluid along with them, so we need another vessel that can pick them up. So lymphatic vessels have big gaps in their endothelial cells that allow for these larger cellular elements to get into the lymphatic vessel, pull the fluid along with them, and the remaining 10% leaves via the lymphatics. So a healthy lymphatic system is necessary to prevent edema. I'm going to say that one more time because it's really important. A necessary lymphatic system. I mean, it's necessary that a healthy lymphatic system is in place to prevent edema. It's less effective teaching strategy when you bumble it the second time. Lymphatics are necessary because if you can't pick up that last 10%, fluid will accumulate in the interstitial space. So I left the PowerPoint slides with this picture, which kind of looks like the picture in your notes. And oftentimes when we draw capillary beds, we kind of draw them like this. But in reality, they look a lot more like this. You can see the web of capillaries because you need a lot of surface area of the individual capillary walls to allow all this gas exchange and fluid exchange to occur. And then the lymphatics are right up in there. They are weaved through and crossing each other and right next to each other to help pick up that remaining 10% of the fluid. So when you go through the lymphatic anatomy, and I like starting on this side of the figure, because we've got the heart as our main pump of our arterial side. Here is our complete circuit where we have arterial blood flow that gets to the capillary. Oops, lost my arrow. And then returned in the venous system back to the heart. But you can see this parallel system of lymphatics. Within the lymph vessels, the fluid that moves in the lymph vessels has its own name, and we call it lymph. And this is written in your notes so you can see it. Lymph is the name of the fluid, sometimes referred to as lymph fluid. What's really important about lymph fluid is, if you think back to the picture we just drew, like what was its main job? It's to pick up all the proteins that couldn't get into the capillary. So then the fluid that's inside of the tubes is a protein-rich fluid. It's carrying a lot of the elements that might have been in the interstitial fluid. It can have nutrients and oxygen, hormones. This is kind of listed in your notes. Cellular waste. It can help pick up toxins, which can be helpful because you can send it to the lymph node and identify things in the body. But for our story, where we're going to come back to this again and again, it's really important to remember that there is a high protein content in your lymph fluid. That's going to be significant to the story. So the lymph vessels transport the lymph from the peripheral tissues to the veins of the cardiovascular system. And I want to spend a little time talking through this anatomy. So the initial lymphatics connect with the main lymph vessels, and they basically get larger and larger as they go. So lymph vessels end up into lymph collecting vessels. These then become lymph trunks that join even larger vessels that ultimately form the thoracic duct. What I don't love about this picture is that in order to give you the details of lymphatics, they don't fully show how big this lymph duct is, or we call it the thoracic duct. But this is like the main central pathway of all this lymph that comes together. And our thoracic duct runs behind our legs, oh my gosh, runs behind our lungs, excuse me. Let me say that again. The thoracic duct runs behind our lungs. It's basically from like the fourth vertebrae to the root of your neck is all your lymphatic duct. It's a really big thing. And I'm mentioning this because our PT interventions related to lymphatic drainage and dealing with lymph fluid, when you take big, huge, deep breaths, the thoracic duct is behind the lungs. So a big, huge breath in actually compresses the thoracic duct. And then when you exhale, it opens it back up. So it's very much, if you think about deep breathing, the lungs around the thoracic duct, almost think of it like the skeletal muscle pump. Like you always draw the skeletal muscle pump as like the calf muscle around the vein. And when this calf muscle contracts, it compresses the vein. And then when it releases, the vein almost has like a vacuum-like element to it, right? Because there's no fluid in it anymore. It sucks the fluid up. That's exactly what happens with the thoracic duct. When you take a deep breath in, it pushes all the blood upward because the lymph vessels are a system that has valves and moves it up. And then when you relax and you release it, there's almost like a negative vacuum in the thoracic duct, and it helps suck the fluid up from the section below. So we'll use deep breathing when treating patients with lymphatics because it actually stimulates lymphatic flow. So many good things about deep breathing. So the anatomy of this is important, but I do want to spend extra time talking about the initial lymphatic vessel, and that's pictured here. This little green guy here is the initial lymphatic vessel. The light green part of this is the endothelial cell. It's a single cell layer of endothelial cells. But they're very unique in that they don't look like a capillary. So let me just draw, you guys have seen me draw this so many times now, right? The capillary vessel has these endothelial cells with tight junctions, and you can see it in the cartoon to the left with obviously the red here is the capillary. But this is what the endothelial cells look like in a capillary. If I would draw a lymphatic vessel at rest, the endothelial cells look like this. They kind of overlap. Very different anatomical orientation than what you see above in the capillaries. There's this, that one got messy. There's this overlapping nature, and that actually allows the endothelial cells to open and close. The spaces between them to open and close. So the actual structure of the endothelial cell is quite different. And then these like little turquoise strings here are microfilaments that directly attach to the endothelial cells. And this is really important. So the surrounding connective tissue, so the bigger blue is our surrounding connective tissue, has these microfilaments that come off and physically attach to the endothelial cells of the capillary. So we could even draw, let's change our color here. So there's like strings, right? Attaching to these endothelial cells that are anchored to the connective tissue of the tissue around it. So what happens is if something increases the extracellular fluid, if there's any kind of swelling at all, the tissue is going to stretch, right? So like if you're thinking about, if you're looking at skin, right, the skin's going to pull away. You can see a bulging. Well, as the skin bulges, that's going to pull on that interstitial arrangement. As the fluid enters, it's going to stretch the tissue. And these microfilaments are going to get pulled away from the lymph vessel. If you pull on those microfilaments, what will happen? So let's redraw this. In a situation where there's any fluid accumulating in the interstitial space and there's force being pulled on these microfilaments, it's actually going to pull the endothelial cells apart. Isn't this cool? It's like a built-in system that when you have swelling, it creates a greater space between the endothelial cells in the lymphatics. And that will certainly help facilitate fluid moving in. Nice big spaces will be big enough for proteins to move in, which is why lymphatics is a protein-rich fluid. So look at this, look at the size of those holes. Easy peasy for proteins to fly into the lymphatics and get sent off into the general circulation. So this is really important, and it actually is directly related to a PT intervention. When you do lymphatic drainage, one of your goals with your hands on the outside of your patient is to stretch these microfilaments in order to induce this change in the initial lymphatics in an area where there is swelling that's not leaving the limb. So you'll see, we'll talk about it in here. You guys will actually do lymphatic drainage in the summer in your physical agents class. You get all of your soft tissue mobilization and you learn about lymphatic drainage. And it's this incredibly soft touch on the skin that you just sort of gently pull the skin. And if you didn't know anything about lymphatics, you might feel like, what are we doing? How is this possibly working? But if you relate it back to the cellular elements involved, if you could put your hand on top of this connective tissue and pull it, right? You'd be able to pull these microfilaments and open up the initial lymphatics. So cool. I obviously love physiology, and when it overlaps and we as PTs do something that actually causes way down at the cellular level, at the initial capillary level, we induce this change, I gotta say that does get me going. I get very excited. I'd be jumping around if we were doing this in person. All right, so let's move on into when this system is dysfunctional, because that's what we're doing here. We're in pathophase. So when there's lymphatic dysfunction, there's a failure in the ability to remove that last 10%. When there is swelling in the tissue related to lymphatic dysfunction, we call that lymphedema. So this definition is written in your notes for you. It's swelling of tissue that results from the accumulation of protein-rich fluid in the extracellular space. So we first were talking about different types of edema, and we talked about transidate and exudate. Lymphedema is the other example of an exudate, a protein-rich fluid. It's a different story, right? The other time we talked about an exudate was in acute inflammation, where inflammatory mediators like histamine increased the permeability, allowing proteins to leave the capillary. In this case, we're failing to remove the proteins, and then in some place even having reflux of a protein-rich fluid from the lymphatics into the interstitial space. So the reason someone might end up with lymphedema can be from kind of two directions. Either the ability of the lymph vessels to move the fluid goes down, so reduced lymph transport capacity. If there's a blockage or a damage to a lymph route, you won't be able to effectively move it out as easily. I often, and I'll use this analogy a couple times in this lecture, when we think about lymphatic dysfunction from reduced lymph transport, it's very much like a 6-lane highway. Like if you're driving from here to Chicago and there's lots of cars on the road, but everybody's flying, right? If they shut down 2 lanes, what is going to happen to the flow of cars getting to Chicago? Dramatic slowdown, backup of cars, right? You're going to get into a traffic jam because you've reduced the lanes of the highway. That is really what happens with lymphatic dysfunction. We reduce the lanes of the highway and we create a traffic jam, here to back up in the system. So that's cause number one. The second would be an increased lymphatic load. So you're creating this edema in the system and the lymphs can't get it out. In terms of presentation, it's most common to occur in the extremities, and that's the picture that you see here on the right. This is obviously her left arm is experiencing lymphedema. This is a very common problem after lymph node resection because of the removal of lymph nodes. So it's very frequently found in the arms, but it also can be found in the legs. And the reason I say it's often found in the arms is because of the high prevalence of breast cancer. So a woman who experiences breast cancer, when they remove the cancer, or likely they remove the whole breast, they will also remove lymph nodes. And that is because, if you remember from the cancer lecture, the cancer cells, the metastasis of the cancer cells, they're most likely to go to the local lymph node first. So they remove lymph nodes, they're cutting down lanes of the highway. So a frequent complication is lymphedema, and then because breast cancer is so prevalent, we see a lot of upper extremity lymphedema. But the fluid can accumulate in many places. You can have it in the head, neck, abdomen, in the genitals. It's just the most common in the extremities. So on the top of the next page of your notes, there is space for you to draw along with me the pathogenesis of lymphedema. So we're going to draw the tissue. For your drawing purposes, you might want to make these in like 3 panels. There'll be kind of 3 progressions of this disease. So I'm going to draw them big on this screen so you can see them, but know that this will be kind of 3 separate pictures in a row, kind of like the atherosclerosis showing progress over time. All right, so I'm going to draw just the skin on top, the dermis here. And the underlying area would have a capillary in it. So I'm just going to draw the capillary relatively small. It's not the main part of this story anymore. And then running nearby is going to be the lymphatic. And the lymphatic will have these initial lymphatics that come off. I kind of think of them as like reaching out into the tissue to try to, get into the interstitial space to be able to pick up fluid. So this area here is the interstitium. It's the tissue space. We've got the capillary, and we have our lymphatic vessel. In order for lymphedema to develop, there either has to be a reduced lymph capacity, a reduced ability to have this flow go through the vessels, or an increased load. I'm going to refer to a reduced capacity as that is much more common, and we see it very frequently in our cancer survivors. It's something you'll treat a lot, and it's just, I'm just going to pick one to kind of focus on in the story to make this a little bit more clear. So, this lymphatic vessel would be kind of draining into those larger collecting vessels and along the way. And something, downstream of this vessel, blockage, but if there was lymph node resection or something limiting outflow of this lymphatic, lymph is going to back up into this vessel. And actually, I'm going to add just one more element to our pictures here, is that the lymphatic vessel has valves. So we're just going to add that in as I'm realizing as I'm getting to the next step, the valves aren't in my picture. So the lymphatic vessel has valves. So the blockage causes flow to back up into the system. So one thing that's going to happen with the backup of flow, I'm just going to erase this to get it out of my way here, is that the lymph vessel would dilate. So if we want to write down the steps, the lymph vessel dilates due to a reduced ability to have the outflow kind of be cleared out in a regular way. So let's just draw this. Let's make it a different picture color. I'm going to make the lymphatic problematic vessel orange. So the vessel dilates, and if, these were the valves, I've really greatly exaggerated this, but you can see that with the dilation of the lymphatic vessel, right, the increase in diameter, we have pulled the valves apart, and as the lymph vessel dilates, the valves become incompetent. And this is significant because it's going to limit our ability to manage how that lymphatic fluid continues to move, because we need to be able to prevent the fluid from refluxing back. With incompetent valves that have been stretched apart from each other, there's really nothing that's going to stop that fluid from refluxing. So with the increased fluid in the tube, we're going to get a dilated vessel. There's going to be some increased hydrostatic pressure in here because of the backflow of lymph, and that is going to cause fluid to leak out. And not just any fluid, right? We're talking about lymph fluid, and it's leaking out of those initial lymphatics, which have big gaps in their endothelial cells. So this is a protein-rich fluid. A protein-rich fluid leaks out. If we wanted to add that as a step here, we could write it down as number 3. Protein-rich fluid refluxes into the tissue space. So what's going to happen if we suddenly increase the amount of fluid in our interstitium? We're going to see visible swelling. So let's draw that dermis as stretching and bulging, because we can physically see this, right, from the outside, because the swelling is going to be pushing on the dermis, and we see visible swelling. All right, let's progress to the next panel. So keeping in mind that we've had this dilated lymph vessel with incompetent valves causing fluid to leak out. So that's the swelling piece, which should sound very familiar to other stories. We talked about swelling. The big difference is that fluid is leaking out of the lymphatic initial vessel, which allows protein fluid to come out, which is very different from if the fluid was coming from the capillary. So let's redraw our picture. This would be panel 2. So instead of drawing the dermis flat, we're going to draw it stretched. So here is our dermis stretched out. The capillary is still there. There's our capillary. And I'll make the whole lymphatic green on this picture now that we're not showing the difference. But here it is, making it quite large with, incompetent valves. Ooh, didn't really fit that one. So we have protein-rich fluid in the interstitial space. And I left the top of my vessel open on purpose because the next thing that's going to happen, once you have protein-rich fluid that's been hanging out in the interstitial space, that's not supposed to be there. And in fact, the job of the lymphatics is to get rid of it. So the presence of protein-rich fluid will stimulate the lymphatic vessel to grow new initial lymphatics. If you want to write that as a step, this would be number 4. This stimulates proliferation of initial lymphatics. The body's always trying to fix what's going wrong in the normal ways that it has kind of accessible to it. So we see kind of multiple lymphatics coming, initial lymphatics. Draw a couple of them coming back here. And even more again coming back. Growth of initial lymphatics. Lymph vessels are trying to kind of rejoin. We see these collateral vessels showing the body's trying to bypass the damaged area. Unfortunately, if the damaged area is downstream, all this growth, I'm just going to add, oops, I'm going the wrong way. Just going to add the valves in so my picture looks more like the one before. If the blockage is downstream, this isn't going to fix the problem. So we're getting all this kind of growth of new vessels, but it's not really doing anything. And we're still having protein-rich fluid hanging around in this space, and it's not supposed to be there. We can't have proteins hanging around. Our body's going to recognize that as something wrong with the system. So the presence of this protein-rich fluid is going to stimulate an inflammatory process. And the body can't get rid of the proteins. They can't fix the problem with inflammation. So this turns into chronic inflammation. We get chronic inflammation in this tissue area because of the presence of the protein-rich fluid. If you remember, chronic inflammation is when white blood cells are on the scene, kind of breaking things down at the same time that you're calling in fibroblasts and you're trying to heal and repair. Breakdown and healing are happening at the same time. So with chronic inflammation, the body's calling in fibroblasts. I'm going to draw these guys as little black doohickeys. These are fibroblasts. And fibroblasts are going to lay down extracellular matrix. And that's what they start doing. They start laying down extracellular matrix. And this chronic inflammation leads to tissue fibrosis. So you could draw that in a couple more places, that we start to get fibroblasts that are causing all of this fibrosis. So now we have a situation where our tissue is chronically having edema, like it cannot clear out this protein-rich fluid. The tissue itself is becoming fibrotic because the chronic inflammation is trying to heal what cannot be healed. And now we have a new problem, because in this capillary is oxygen that is supposed to be being delivered to the tissue here. But the oxygen molecules have to leave the capillary and diffuse through the interstitial space. When you have this extracellular matrix, this is going to impede oxygen diffusion. Furthermore, especially if you think about the dermis and the health of the skin is physically further away from the capillary, because that should be distance. I don't know if D would mean enough for you guys. Increased distance, because the swelling has pushed it away from the capillary. So you have both a worse environment for oxygen to diffuse through and a further distance to go for cells of the skin and the dermis. So what we see here is when someone has chronic lymphedema, they end up in a state of hypoxia, tissue hypoxia. This state of hypoxia is going to create a very unhealthy environment for the tissue around it, and what we often see is the skin. because the skin is very far away from its oxygen source, it becomes relatively unhealthy, which we'll talk about a little bit more in the clinical manifestations. But the other really big thing to think about with this state of hypoxia is that there would be a reduced ability to heal if anything happened to this tissue. Right? If you had some kind of cut in the dermis, think about how hard it would be to mount a normal acute inflammatory response here. It's further away, it's fibrotic, to get the white blood cells through all this extracellular muck to get to where they need to go to do their job becomes more and more difficult. So this state of hypoxia causes an increased risk of infections and delayed wound healing. And this is primarily related to the impediment to diffusion and movement within the interstitium once the tissue has become fibrotic, as well as the distance away from their capillary oxygen source. So I actually think I can add the very last step onto this picture because I think we have enough room on here to add it just to here. The stretched tissue and the increased distance for gas exchange causes poor cellular metabolism. And then, the lymphatic vessel is still trying to fix this problem. And it's not doing a good job removing waste from this area. And so what happens is the muscle wall of the lymphatic vessel starts to hypertrophy. So we can just draw some kind of red lines in here to show that the smooth muscle wall begins to hypertrophy. What number are we on here? So that would be number 7, is we see lymphatic muscle wall hypertrophy. But like any time that we see hypertrophy kind of for a bad reason, it doesn't necessarily mean it does its job better. In fact, it grows so much that it actually decreases the effective pumping power of the lymphatic wall, which is very counterintuitive. As the lymphatic wall hypertrophies and gets thicker, this actually decreases the effectiveness of the pump. And they get even worse at removing lymph fluid from the limb or wherever the lymphedema is occurring. So we have an intact capillary here, but protein, fat, cellular waste, and 10% of the tissue fluid that's leaking out cannot get into the venous system. And now they don't have another transport mechanism. So protein-rich fluid accumulates. This presents itself as swelling. Initially, it's just swelling, but things get dramatically worse because the fluid that is stuck in the interstitium is protein-rich. And the body responds to protein-rich fluid with inflammation. But the inflammation will never fix the problem because it's the lymphatic vessels that are blocked. So chronic inflammatory state results in the deposition of extracellular matrix causing tissue fibrosis. So now we still have the initial problem of the swelling, but now we've created a state of relative hypoxia, where we've stretched the skin far away from its blood supply, making the skin less healthy, worse ability to tolerate stress and damage, significantly impaired our ability to heal if the dermis gets cut or fight off an infection if bacteria gets in. And there really is no end in sight here because the lymphatic vessel is still blocked. So I encourage you to keep the I just lost my screen for a second. I encourage you to keep this picture in mind. The skin stretched away, the black lines representing this tissue fibrosis. When we start talking about the clinical manifestations, So hopefully it'll help make sense. All right, the next piece in your notes talks about the stages of lymphedema. And this, again, should play into the story we just told. Stage 0 is latent lymphedema. Basically, you have the clinical impairment that can lead to lymphedema. So something has impaired your lymph transport. You've had lymph node resection or something done to your lymphatics, but you don't yet have any swelling. This is a really, really critical time. Patients who have had these type of surgeries should be educated on the early signs and symptoms of lymphedema, because you want to aggressively treat this as early as possible. If you can do something to facilitate moving the fluid out of the tissue space, you could potentially prevent or delay the kind of long-term effects that involve the fibrosis and the effects on the skin. Stage 1 is the swelling is still soft to the touch and it pits on pressure, which means that there's protein-rich fluid, but there's not so much there that you can't overwhelm it by, or excuse me, I should say, you are able to overwhelm the amount of oncotic pressure with the pressure of your thumb. So you can push into the skin and actually alter Starling's forces to drive fluid back into the vessels. That would be pitting pressure. So this is pretty early on in stage 1. If you elevate the limb, the swelling should go down, because if you elevate the limb, gravity will help wash it out. So the fluid is still able to leave. That's a really big part of stage 1. Once you get to stage 2, you now have non-pitting edema. And by that, we mean there's so much protein-rich fluid. The oncotic pressure of that fluid is so high that even if you push on the swelling, no fluid is being driven into the vessels. The oncotic pressure of all those proteins holds the fluid in the interstitial space, so there's no mark where your thumb was. Similarly, this will not diminish the swelling if you elevate it. The fluid is really at this stage being trapped in this limb, and there's so much of it that you really can't reverse it with elevation. Stage 3 is sometimes called lymphostatic elephantiasis, and this is a severe form of lymphedema where you have severe non-pitting fibrotic edema and trophic skin changes. So trophic skin is thick, shiny, hairless skin. It just appears to be unhealthy. The patient in this picture actually has pretty nice looking skin for stage 3. We'll have some pictures later that represent more of the trophic skin changes. This picture actually helps to represent some of the worst effects that can happen on the skin. So what patients might feel is like a full sensation in the limb. They might actually notice the skin tightness before they even notice the swelling. A reduced ability to move the joints. If there's a lot of swelling, they might notice that their hand isn't moving well before they notice their hand is swollen. It's very common that the thing that draws it to their attention is difficulty getting clothes to fit in one limb but not the other. This can be hard sometimes, I think, for young, healthy people to appreciate, but older individuals, especially if they're overweight, noticing swelling is not always as obvious as you might think. And that's a dangerous thing with lymphedema, because the longer you go, the further you get down kind of those panels of our drawing. And you want to start to intervene as early as possible. So educating people on, noticing swelling and being aware of that, but that might be the first time they notice it is when they're trying to get dressed. This can cause neuromuscular deficits because of the effect of the fluid pinching on nerves, and then a lot of integumentary changes. So it's common for the skin in that area to get eczema. You can develop warts. We talked about the trophic skin changes, like thickened, leathery skin. Patients can develop skin flaps and skin tags on that skin that's just so unhealthy. The presence of all that fluid behind the skin can actually cause what's called leaking lymph fistulas. Maybe I'll write that one down. Leaking limb fistulas, where the fluid actually starts to kind of weep out through the skin. And then what's also referred to as keratotic skin, which is very much seen here in this picture. Excessive growth of corny tissue can happen with the skin. So in order to get this diagnosed, the only way, or the way that's most often done, is that patients who are at risk are diagnosed when they have signs and symptoms. So they don't do further tests if you had lymph node resection and then 6 months later you have a swollen limb. You will be diagnosed with lymphedema and begin treatment. They're not going to put you through tests for it because they know the cause. If someone gets lymphedema and there's really no reason why, or they don't know why, then they might do things like MRI or CT scan, ultrasound. And they're really kind of trying to look for the cause, like look for a blockage, look for a tumor that might be causing the lymphedema. But you might see a host of tests that were done in the patient before they got referred to you if they really didn't know why the lymphedema was there. So when it comes to treatment, it's important to know that this is a very common side effect in patients who have or have recovered from cancer. And of the two, cancer is worse. So at the time, if they start to have signs of lymphedema and they're still needing oncology therapies and treatments, that will always take the priority. But if the patient's open to it and they have the time and the ability and the energy, then you can begin lymphedema treatment. It's just sometimes it gets put on the back burner because there are much more pressing issues to be addressed. There is no medication for lymphedema. And it's important to know that so you can be a patient advocate, because it is still sometimes prescribed to patients to take a diuretic, which does not make any sense. That is on a basis of someone who doesn't truly understand the pathophys of this disease, because this is not edema that's driven from too much volume. It is driven from an inability to move proteins out of the interstitial space. And a diuretic will not help you, right? You pee out water, you're not removing the proteins. So it's not appropriate, but you might see that, and I wanted you to know kind of the inappropriateness of it, and you can speak up for your patients and have a respectable conversation and maybe get them off that med. There is an option for surgery, and the idea for surgery is that you would, anastomose means to connect two vessels, so you would take a lymph vessel or a vein that was open and healthy and try to tie it into the lymph system to basically give it an alternate route out. You're trying to add lanes to the highway, if that makes sense. So you're trying to sew two vessels together so you can bypass the obstruction. This sounds much better than it actually works out. First of all, we're talking about microsurgery here. This might be bringing to your mind the idea of a coronary artery bypass graft, where we take vessels from other areas and use it to circulate the heart. Those are much, much bigger vessels. These are teeny tiny little vessels that they're trying to do this surgery on. So what very frequently can happen is that scarring occurs at the site of the surgery, which actually will cause further blockage of lymphatic vessels. That being said, it might be tried if things are really bad. Like if it's causing severe skin effects, if they're not responding to treatment, they might opt for surgery. But it's risky, not in a life-threatening way. It's risky it might not help, and in fact, it can sometimes make things worse. But PT interventions, that's kind of a downer, but here's the positive. PT interventions can do a ton for this. It's so exciting. So we can make really, really big gains for patients that improve quality of life who are dealing with lymphedema. So there's kind of a laundry list here because there's a lot of things we can do, but let's start talking about each one. So the first up at the top is manual lymphatic drainage. And this is what I referred to earlier. You guys will be doing this on each other this summer, which is very exciting. It's an extremely gentle stroking maneuver that you do to the limb. And it is meant to encourage lymphatic flow. So this is not, if any of you have treated patients with like a sprained ankle and you do some kind of aggressive massage to try to move fluid, this isn't that. This is very gentle. And what you're trying to do is manipulate the intact lymph vessels by very gently stretching their walls and opening up the initial lymphatics to encourage lymph flow. Now, this is highly effective because if you're opening up lymph vessels around the area, you can drain some of this fluid out. Because it's so effective, you have to be careful with this. And I like this picture on the slide because you can see this leg is rather large. And if you got a lot of that fluid to move up, it's important to know where you're dumping that fluid into. So you always want to check more proximal areas to make sure that they don't have lymphedema somewhere else. So if they had a leg that looked like this, and then they had groin lymphedema, and you moved the leg fluid and dumped it onto the groin, that could be incredibly painful. So you want to check everything proximal to make sure that the flow is open and that when this fluid is moved, you're not just dumping it to the next site up the road. The next one is short stretch compression bandages, which you see here. Compression bandages have it's written in your notes, they have a low resting pressure. So again, I think oftentimes we think about a swollen ankle. I think that's just like one of the more common things you guys have seen in your life. You've sprained an ankle, a friend sprained an ankle. You might have wrapped an ankle where you go real tight distal and then you loosen it up more proximal to encourage the fluid to move out. That is not what this is. And as it says in your notes, these bandages have a very low resting pressure, meaning they go on very light, but you do this crisscrossing pattern so that when the hand moves, they have a higher working pressure. So short stretch compression bandages are not meant to drain fluid. They are something you apply after you do the manual drainage. So once you've moved the fluid out, you don't want it to just come back in. So you do the lymphatic drainage and then you apply the bandages. And these have to be worn 24 hours a day. And the goal is to try to help maintain the edema reduction you did when you did the hands-on drainage. Very similarly is compression garments, seen here. And this one's cool because it looks like a tattoo, but it's a compression garment, which I think is awesome because many of these are like hospital grade Caucasian color, and that is inappropriate for many, many reasons, but it's also very medical and not pleasant. So there's a whole host of companies now that make super cool compression garments, empowering women. Not that only women get this, it's just so common with breast cancer that I often think about the women that get to just rock some sweet arm tats when they're wearing their compression garments. So this is the compression garment. Similar to the short stretch bandages, this does not decrease the fluid. So it's not like a TED hose where it's squeezing it up the limb. This is meant to hold an already reduced limb. These are extremely custom fit. Every individual would have a garment made just for them. So it's not something you can buy off the shelf. It's important to educate patients on what these garments do and what they don't do. You can't skip the drainage steps and think the garment is going to do you any good. It only holds the drainage that the manual techniques have already done. Number 4 is a compression pump, and that's very much like what you've seen, what we showed in the thrombosis prevention, just leg or arm cuffs that squeeze and try to promote fluid. So this has very limited benefit in lymphedema, because think about what a compression pump does. And I'm just going to jump back into our drawing for a second. So if this is going on under the surface and you put a compression pump, and let's just do like a big thing on the outside of the dermis. So this could be your pump. It would go all the way around the limb, and the pump is going to just squeeze the limb, right? So it's going to push down on the dermis. What does that do inside of this tissue or inside of the interstitial space? It's going to raise the hydrostatic pressure of the interstitial fluid, right? So the goal of the pump is to drive fluid back into the venous capillary, if there are lymphatics that are open, but you're smashing this down into it. So basically, in stage 1, when you just have a reflux of fluid, the pumps might work a little bit because they can raise the pressure and they drive some of that fluid back into the system, and perhaps it has some minimal effect. But in this picture that you're looking at, if you raised the interstitial, the pressure, and maybe you were able to drive some fluid back in, maybe you did drive fluid into the venous circulation. Let's think that through. So if fluid goes in, what's left behind? And again, remember, we're dealing with a protein-rich fluid. If you drive the fluid in, what's left? You've basically concentrated the proteins, right? The proteins can't get in. So you have all the proteins still there. Then you take the pump off. What's going to happen? What are the proteins exerting? A super high oncotic pressure. And they're going to pull all that fluid back out. If anything, you might even get a rebound effect where you can get some increased swelling after. So there's limited possibilities for this to be helpful in stage 1. But once you are past stage 1, you are moving fluid and not proteins with these pumps. So it's really not effective. So if we go back to our list, all right, number 5 is going to be exercise. So exercise can be very helpful in moving fluid, because if you prescribe it right, you can enhance the natural pumping process of that tissue. So in your notes, I have some basic precautions, and it's all kind of related to limb anatomy. Do you remember the big thoracic trunk, and then it spreads out to the limbs? So you want to try to get lymph fluid moving, and the best thing to do would be to get it moving proximally first, like the big central passage. So when you do exercise, you work the trunk muscles first, kind of warming up the trunk, getting the thoracic duct experiencing a pumping motion so that fluid is moving a little bit better. Then you go and do the limb muscles. You lift the weights or you do whatever your exercise is, which might help facilitate lymph movement. During the exercise, we enhance the natural pumping process. So when you're exercising the limb, you're sending lymph fluid back to those proximal vessels. So then you finish by exercising the trunk again, because that's where you just dumped the fluid. So you start by in the thorax to get the flow moving. Then you work the limb that has the lymphatics, and you end by working the trunk again, and then ultimately ending with really deep abdominal breathing to just maximally pump that thoracic duct. When patients are exercising, they should always have their compression garment on, because exercise can potentially increase congestion. So that kind of gets to this slide here where it's talking about exercise precautions. You want to watch for signs of limb overload, meaning the limb is becoming more congested with fluid than when you started. And this can happen because you're delivering more blood to that area, and that can increase the hydrostatic pressure with the increased blood flow and increased systemic pressures, and that can potentially drive fluid out. And that's not what we want, which is why they always exercise with a compression garment on. That is not fail-safe. It just helps to limit this. But educating patients on signs of overload, which would include aching in the limb, a congested, full feeling. If they get pain or discomfort in their proximal lymph node area, that would kind of suggest that the lymph node is being overwhelmed. Pain, throbbing, or changes in skin color. If they're experiencing any of these signs, you should stop exercise, because the exercise is actually making things worse at this point. And then you want to do something to help treat it. So elevating the limb, letting gravity be your friend to help pull that fluid in. Maybe putting a cold compress on the limb that can cause a vasoconstriction and limit blood flow in the area. Do really big, deep breathing to facilitate that thoracic duct lymph movement. And maybe even doing some self-lymph drainage where they are trying to encourage that fluid from coming out. So exercise is good. We have to be really smart about it and be ever vigilant for signs that it's causing trouble. As PTs, we can provide a lot of education to patients about what their condition is and how they can live with it and treat it. On the education front, it is very likely it could be our job to notice the lymphedema in the first place. So always watching for signs and symptoms for those patients who are at risk. If they've had any kind of radiation, lymph resection, just check the skin every day. Just take a look at it. You can even do, girth measurements if you really think that they're at risk or you're kind of wondering if you're seeing signs. As it says on the slide here, and I think not in your notes, most patients don't report the edema until it becomes severe. The reasons for this are kind of across the board. Anecdotally, a lot of times these are patients who just went through a lot of treatments, and your body is very weird when you're being treated with cancer. The drugs do all kinds of things. It is easy to overlook a little bit of swelling. There might be a bit of burnout on medical treatments, and so if you notice a little bit of swelling, you might not be interested in reporting it. But this is a condition that if left, once fibrosis is there, you can't get that out. So if you can catch this in the earlier stages of development, you can manage the accumulation of fluid and do techniques to get that protein-rich fluid out of there so you don't end up going down the path where you get the full fibrotic effect. So it's not a super easy sell. You have to be just talking to patients and trying to walk them through why these treatments are so important and the permanentness of the fibrotic changes that could occur. Helping patients understand risk reduction strategies, so things that they can do to not cause overload. Heat is kind of a big one, like especially if your legs are in a dependent position, if it's a leg edema. So heat is a big vasodilator, so you're going to send a lot more blood to that area. Talking to patients about that. This is a big one that cannot be understated. That dermis is pushed way far away from its blood supply. The skin outside of lymphedema, especially in the later stages, is not healthy, and it's extremely prone to infections. Patients need to understand the severity of minor scratches and cuts on their skin as being much more serious, So even local areas of redness, the example I always get, because I feel like so many of us can relate, I always refer to them as my summer feet. That first week or two of summer when you're like trying out the sandals you haven't worn in a year, and you always get like that red area right at the heel where the strap is, and it's annoying, and that's about it. Little irritations like that can be very serious if your body isn't good at healing. So I just put that in your head. I think sometimes these little things can help you remember it when you're studying, because I'm hoping many of you have, experienced that and blown it off. Like, shoot, I got a blister, but that can be a really big deal. So they have to treat these aggressively. They should always carry a first aid kit with them, applying antibacterial creams, as soon as they get minor cuts, and just kind of, aggressively treat any minor injury. So that is the pathophys part of lymphedema. You guys are going to get more on the treatment side of it. We actually have a lymphedema specialist that comes in. She's great, that you guys will work with over the summer. So if you're interested in this type of patient population, more is to come. And either way, when you hit this stuff in the summer, I really encourage you to either read through these notes again, or when you're doing your treatment techniques, to really try to picture what's happening within the tissue to appreciate how your interventions can make a difference. All right, have a good day.